Hello and welcome again. This is the second part of infective endocarditis presentation. My name is Dr.جين. We are completing our agenda from the previous part. Now reaching the diagnosis of infective endocarditis, we have what is called modified Duke's criteria for diagnosis, which are divided into major criteria and minor criteria. The major criteria are two. First of them is a positive blood culture, and second one is evidence of endocardial involvement. As regard the positive blood culture, it is described as a major criterion if a typical organism is found in two separate cultures, or there is persistent positive blood culture with another organism, at least 3 cultures with 12 hours or more apart. As for the endocardial involvement, there should be a positive echocardiography sign like vegetation, abscess, dehiscence of prosthetic valve. Dehiscence means rocking or shaking of the valve due to the subvalvular abscess or mass. Another evidence of endocardial involvement is a new valvular regurgitation or a new valve regurg that was not found before. As for the minor criteria of diagnosis, a predisposing condition like cardiac lesion, IV drug abuse, cardiac surgery or catheter, fever more than 38 Celsius degrees, vascular or immunological sign, positive blood culture and or echocardiogram but doesn't meet the major criteria. So how to score the diagnosis? You have to find at least 2 major, 1 major and 3 minor, or 5 minor criteria to confirm infective endocarditis diagnosis. Investigations to be done: blood cultures, ESR, CBC, urine analysis, echocardiography, and chest X-ray. ESR is always elevated, except when heart failure occurs, it declines. Blood picture is not so much characteristic, but it usually shows normocytic normochromic anemia, monocytosis, and leukopenia. Sometimes leukocytosis occurs if embolization found. As for the blood culture, you have to take at least 2 5 cultures done on 2 to 3 successive days. For each culture, you have to aspirate an adequate amount of blood, 20 to 30 cc's. Culture has to be made on solid media and fluid media under both aerobic and anaerobic conditions. If the patient was receiving penicillinase should be added to the culture. Cultures, if properly done, are 90% positive. However, there are some cases of culture negative endocarditis occur in fungal endocarditis, a prior use of antibiotics, and other causative organisms like the mycobacteria, Q fever, and chlamydia. Urine examination reveals microscopic or maybe macroscopic hematuria, slight albuminuria or hyaline casts, or maybe up to massive albuminuria in patients with nephrotic syndrome. Echocardiography, it is an important investigational tool for diagnosis and monitoring of the disease. 2D echo can detect 80% of vegetation cases. Vegetations should be at least 2 millimeters in size to be visualized by echo. However, negative echocardiogram does not exclude the diagnosis. It also provides information about the pre-existing cardiac condition. It will also show perivalvular abscesses. Doppler echo is particularly useful in diagnosis of perivalvular leak in patients with dehiscence of prosthetic valve. Serial examinations are important to demonstrate any increase in the size of cardiac chamber, any deterioration, any improvement. Sequential studies of the cardiac function help in making decision of the necessity and timing of surgery. This is a photo of a transesophageal echocardiography showing a large mass attached to the mitral valve leaflet. This is a transthoracic echo showing the same mass. As for the chest X-ray, it gives us a picture of early congestive heart failure. Also, it may demonstrate multiple small patchy infiltrates in the lungs, suggesting septic infarctions due to embolizations from a right-sided vegetation. The classical appearance of chronic fever with cachexia, anemia, café au lait discoloration, clubbing, and palpable spleen are late signs. Any obscure fever for more than few days in a predisposed patient should be diagnosed and treated as a possible infective endocarditis until proved otherwise. Infective endocarditis simulates rheumatic activity but must be differentiated from it. In cases of rheumatic fever, there is always fleeting arthritis and erythema marginatum, which is like pinkish or reddish patches around the joint. These signs and symptoms are absent in infective endocarditis, while in infective endocarditis you are expecting to see petechiae under the nails, hematuria, clubbing, splenic enlargement, and signs of embolization. As for the culture, it is always negative in rheumatic fever, but it is mostly positive in infective endocarditis. Prophylaxis against endocarditis. Patients to be taking the prophylaxis are divided into high, moderate, and no risk. High risk patients are patients with prosthetic heart valves, previous bacterial endocarditis, complex cyanotic congenital heart disease, and surgically constructed systemic or pulmonary shunts. Moderate risk patients are patients with rheumatic and other acquired valvular dysfunction, hypertrophic cardiomyopathy, mitral valve prolapse with regurg, and other congenital heart malformations apart from the ones listed in high risk. Patients with no risk and no need for endocarditis prophylaxis are patients with isolated secundum ASD, surgical repair without residual beyond 6 months, previous CABG, mitral valve prolapse without valve regurg, functional and innocent murmurs, previous rheumatic fever without valve involvement, cardiac pacemakers, and implanted devices. For prophylaxis needed to be done for patients with predisposing cardiac lesions undergoing procedures known to cause bacteremia, correction of the predisposing cardiac lesion, if possible, is recommended. Good oral hygiene is recommended at all times. For dental, oral, and upper respiratory procedures, there is a low-risk regimen and a high-risk regimen, as stated here. For GIT and genitourinary procedures, it is always recommended to take the high-risk regimen. The curative treatment. First step is to consult a microbiologist and cardiologist as soon as suspicion is evoked. Achieve a bactericidal concentration of the drugs because microorganisms are sheltered in avascular tissues in the vegetation, so that is why always use the bactericidal antibiotics in a very big dose for a long period, and start empiric therapy while awaiting the results for culture. Empiric therapy is benzyl penicillin plus gentamicin, and if acute you can add flucloxacillin to cover staphylococci. Curative treatment is the treatment specific for each organism as proved by the serial cultures to be aspirated. Organisms expected to be either streptococci, enterococci, staphylococci, coxiella, or fungal infection. In any case, for penicillin allergy, use vancomycin 1 gram per 12 hours instead. Surgical treatment when needed, it's always composed of replacement of the infected valve with a prosthesis. If the infection is on a previously implanted prosthesis, should be removed and another new prosthesis will be planted. Surgical treatment is indicated in refractory heart failure cases, in myocardial or perivalvular abscess, in persistent bacteremia, in fungal infection, in repeated attacks, in unstable prosthesis, in multiple embolic episodes. Do it after several days of the best available antibiotic coverage before. Urgent surgery for native valve may be indicated in cases of life-threatening hemodynamic instability, additional factors favoring earlier intervention like congestive heart failure, multiple embolizations, infections resistant to antimicrobial therapy, fungal infection, even if bacteremia is still present or if antibiotic treatment is ongoing, surgery may be proceeded. Prognosis is about mortality about 30% with staphylococci, 15% with bowel organisms, and 7.5% with streptococci. In cases of prosthetic valve endocarditis, a prosthetic valve, whether it is tissue valve or mechanical, is a very high risk condition for development of infective endocarditis and at any time. The increased risk is due to the endothelial damage and exposure to bacteremia during the surgery. Active endocarditis can occur early within 2 months of the surgery or may be late up to 10 years after surgery with an incidence of 5%. Early prosthetic endocarditis, the patients have a high mortality rate between 30 and 90%. Staphylococcus epidermidis account for 30% of cases, while other organisms account for the rest. Sources of infection may be from the medical member themselves, contamination of the blood from the oxygenator, or infected sternal wounds, or maybe from the postoperative drains and catheters. Patients in this condition are seriously ill and often have rigors. Prompt surgical replacement is indicated. While in late onset prosthetic endocarditis, the microbiological pattern is similar to the conditions of endocarditis on native valves. Most may be initially treated with antibiotics. Some of them may indicate valve replacement. And this is the end for our presentation. Thank you very much.